Good evening. My name is Russell Burgum. I am a physician with Regenexx in Des Moines, and I practice interventional orthobiologics, and I will go over what that actually means tonight. And the focus of our talk tonight is to discuss how you can use your own cells to treat orthopedic conditions and help avoid surgery. Uh, in 2005, Regenexx was the first clinics at the Centennial Schultz Clinic in Colorado to use stem cells to treat orthopedic conditions. This is all in the field of what we call orthobiologics or interventional orthobiologics. That is one of the most high-tech, most recently emerging um, medical subspecialties, spinning off of what was previously called interventional orthopedics. What that means is using high resolution imaging, such as an ultrasound machine, such as the picture here, or X-ray guided X-rays, real-time X-rays called fluoroscopy, using high resolution to guide injections into orthopedic structures such as joints, ligaments, tendons. Orthobiologics refers to using your own cells as opposed to using drugs such as cortisone or different steroids to be injected into these areas. So interventional orthobiologics is using high resolution imaging studies to precisely guide injections into your body. So we use this to facilitate healing in bone, tendon, ligament, muscle, cartilage, and use very high precision guidance. So I'm sure many of you may have had some type of injection in the past, and what is interventional orthobiologics as opposed to some of the simple injections? Well, a standard sort of simple injection is something that would be done in a clinic or a hospital, which is a palpation guided injection, meaning the physician or oftentimes a non-physician, such as a nurse practitioner or physician's assistant, palpates where the joint is and does a simple injection into the joint. And those types of procedures represent roughly 95% of procedures done across the country. About 4% of US physicians will use intervention or guidance such as fluoroscopy or ultrasound, and 1% actually use orthobiologics, using your own cells to promote healing. So a big difference is when I treat your dysfunctional or damaged part of your body, such as your knee or your shoulder, I don't just simply put an injection into the joint. We look at the whole structure and look at how can we make that joint more stable and function more securely, in addition to treating the degeneration within the joint. So rather than doing just a simple injection into the joint, we would do that, but the procedure would also include injecting into the tendons or the ligaments around the joint or the lip of cartilage called the labrum, or into the bone itself if the bone is breaking down and needs to be promote healing from the inside out. So in this area, you can see the different areas of a hip that might be injected as opposed to just a simple joint injection. On this diagram, it shows all the different structures around a knee that might be injected. And in the shoulder, there are numerous areas, the rotator cuff tendons, the ligaments, the supporting ligaments, the joints. We can block pain into the area using a nerve block prior to the procedure. So we are very different from your typical quote stem cell clinics that you may see or hear advertisements on. For one, all procedures at any Regenexx clinic are done by highly trained physicians, not mid-level providers. And we use high resolution fluoroscopy, X-ray, or both, and ultrasound. Your cells, be it cells from your blood, from a blood draw, or from your bone marrow, are processed in uh, our own clean room special lab, and not just processed by a simple bedside machine. And this is backed by a multi-million-dollar research facility in Colorado, and where they also have a fellowship training program in Colorado. And there are currently now more than 90 Regenexx sites around the country, and several in other countries. But one big advantage of being treated at a Regenexx clinic such as our clinic is we have always tracked how well and for how long our different procedures work. All Regenexx procedures are, one, based on science, based on published research that has been done to show that these particular procedures are effective, and two, based on data as to how well they work. Back in 2005, the Regenexx founders had the foresight to say, let's track how long and how well these different procedures work. So as a result, they set up what's called our Regenexx Patient Outcomes Registry. So what that involves is, before any patient has a procedure done, we ask you to fill out a questionnaire, a survey, asking you questions about what is your pain level? How does this affect your life? What sorts of things makes it better or worse? And how does this affect your daily activities? Then after a procedure is done, you will get similar questionnaires emailed to you every few months initially, progressively spacing out to every 6 months. And by the 2-year period, you will get the surveys once a year for up to 20 years. So as a result, Regenexx has the world's largest orthopedic outcomes database, and we use that to tell our patients how good of a candidate you are for a procedure. Every patient that comes in is I determine a candidacy rating from good to fair to poor, and with subtleties in between, like you may be a good to fair candidate or a fair to poor candidate for a given procedure. And that candidacy rating all starts with this enormous amount of data that we've tracked to see how well the procedures work. On top, that is used as a baseline. And then I also look at you as an individual person. What type of healing environment do you have in your body? Because there are lots of things that can affect how well you respond to these procedures, because these procedures stimulate your body's own innate healing. So the better of a healing environment we can get before the procedure, the better chance you have for success. So in our clinic, I will look at what's your diet like. Do you eat a pro-inflammatory type diet with lots of processed foods, fast foods, simple sugars, or do you eat an anti-inflammatory diet focused on fruits and vegetables and healthy oils such as extra virgin olive oil and healthy nuts? And if not, we work to try to transition you into a healthier diet and a healthier lifestyle to try to make your chances of success as high as possible. So the Regenexx outcome database, well, these numbers might be a little outdated. I last pulled these up a couple weeks ago, so these numbers are continually going up. But the areas that are followed and treated, or I should say the areas that are treated and tracked in our registry database, include the knee, which is the most commonly treated area. We have over 20,000 cases being tracked in that for knees. Lumbar spine is next with over 16,000, followed by shoulder, hip, the neck or cervical spine, foot, ankle, and hand and wrist and elbow. And these are numbers across the whole Regenexx clinics across the country. So different clinics may have different areas of emphasis. In my clinic, I do not do spinal procedures, so the cervical and lumbar spine numbers aren't ones that I'm contributing to, but I see a high number of knee, foot and ankle, hip, shoulder, and elbow patients. So when we talk about interventional orthobiologics, here's what it would look like, for example, with a fluoroscopy machine. This device here is like a real-time X-ray, and the picture above shows an injection going into the joint, into a knee joint in between the kneecap and the thigh bone, and below it is an MRI image showing the areas of pathology in that joint. So another thing that we can do in interventional orthobiologics, we can treat ACL tears, or the anterior cruciate ligament in the knee. That has two different bands, and we can target each of those using the fluoroscopy machine. And this picture here shows a fluoroscopic image. The dark kind of globs are contrast dye that was injected, tracking up into the bands of the ACL. And we can treat shoulder injuries, shoulder labrum tears. This on the right here shows images of injection going into the shoulder joint, and then the shoulder labrum, which is a lip of cartilage along the edge of the socket. We can treat carpal tunnel syndrome. This is an ultrasound image showing injection bathing the median nerve in the wrist. The median nerve is the nerve that gets compressed and damaged in carpal tunnel syndrome, and we have good treatment using a product called platelet lysate, which I'll talk about in a little bit. So why would anyone even want to do something like this? Well, for one, we have excellent data showing that we can help patients avoid orthopedic surgery, elective orthopedic surgery. I'm not talking about if someone has a broken bone and it's malaligned and it needs to be straightened and screwed together. Those are not elective surgeries. Those are traumatic surgeries. But we can help you avoid elective surgery. This is less invasive. Patients recover quicker. You have less downtime. You don't need to be in the hospital. After a patient has a procedure, they get up and they walk out of the recovery. I mean, out of the procedure room to the recovery room. And you get to keep your own parts. You preserve your biomechanics. We don't cut out, your bones and replace your knee with an artificial joint or your hip with an artificial joint. So the other thing is we have, through all of the data that has been collected, the Regenexx has been able to show that we can not only avoid surgery, but we can treat these conditions for less money than a company might pay through their insurance plan for their employees to have this done. So as a result, there is now a large program called the Regenexx Corporate Program, where there are currently over 2,000 corporations that provide self-funded insurance coverage to their employees, over 2,000 companies that will cover Regenexx only regenerative medicine treatments for orthopedic conditions. And that the list of companies is growing, and companies have been signing up to provide Regenexx coverage to their employees because our data shows we have excellent outcomes, and patients get back to doing the things they love quicker, and we've shown it can be much more cost effective to the company. So when we talk about orthobiologics, what are we talking about? Well, in the two largest types of procedures we do in Regenexx clinics would involve platelet-rich plasma and bone marrow aspirate concentrate or concentrate. So platelet-rich plasma is a process where we use your own concentrated platelets from your blood to help to heal injured or dysfunctional or degenerated structures, such as arthritis in a joint, or the cartilage is wearing down, or degenerative tendon tears, such as rotator cuff tears or um, gluteal tendon tears. When people have pain on the side of their hip, that the bump of bone there, that's where your gluteal tendons attach. So how do platelets do this? Well, platelets are cells in your blood that um, we most often think of as platelets as being the thing that stops you from bleeding when you get a cut, and that's one of their functions. Platelets will begin the coagulation cascade to help you to stop bleeding. How they do this is quite amazing. Platelets will release numerous growth factors when they come into contact with connective tissue. These growth factors stimulate different cells to grow and to heal. So when platelets come into contact with connective tissue, they release these numerous growth factors to that start the healing process. And there are growth factors for. I'll go over them in just a minute. But there are growth factors for all different cell types. Um, and we do this by extracting platelets. Well, first, the patient has a blood draw, and we draw many vials of blood and then separate out the plasma from the red cells and the white cells. And in the plasma is where all the platelets live. We then can extract those platelets and reconstitute them in a very small volume of plasma. And that is how we increase the concentration of platelets. So we can, in Regenexx clinics, we can concentrate the PRP to many, many times higher than is found in your blood, and many times higher than what other clinics can do with their simple bedside machines, um, to put a high dose of healing growth factors right in the area that you need it. So this next slide here shows some of the many different growth factors that are released from platelets. So there's growth factors specifically for collagen, for skin, for connective tissue such as cartilage or ligaments, growth factors to promote new blood vessels coming into the area because our tissues need blood for nutrition. There's growth factors that will stimulate stem cells in the area to become more active. Our bodies have stem cells all throughout our body, waiting to come into action to promote healing when there's an injury. Platelets will release growth factors that stimulate your own stem cells, as well as transforming growth factor, which will stimulate your stem cells to transform into their final cell type. So stimulate, for example, a MSC, mesenchymal stem cell, to convert into actual cartilage. We also use a product that's it's your own cells, but if we take platelets, we can break down their cell walls in the lab to release all of those growth factors and then filter out the cell walls, and what's left is plasma with all of these enriched serum growth factors, and that's called platelet lysate modified. And you can kind of think of that as like an immediate release medicine as opposed to an extended release medicine, because when we inject regular platelet-rich plasma, those platelets release the growth factors slowly over 10 to 14 days. Platelet lysate, when we inject those growth factors are available immediately. So we use that. I mix in platelet lysate with platelet-rich plasma for different procedures, such as when I'm injecting into a joint or into a tendon or a ligament. And we use platelet lysate by itself when we're injecting around a nerve that's not functioning properly, such as with carpal tunnel syndrome or like impinged nerves coming out of the neck or the back. And then there are the MSCs, or mesenchymal stem cells. So we isolate and concentrate these stem cells to a much more higher degree than other clinics can do with their simple bedside centrifuges as well. And we get them from bone marrow aspirate. And the bone marrow aspirate, aspiration means to suck or to withdraw something out of your body. So we obtain the bone marrow from the backside of your pelvis, and the backside called the posterior iliac crest. And these MSCs have numerous healing properties and more potent growth factors that we employ for more advanced conditions, such as moderate to severe knee arthritis or higher grade tendon tears in the shoulder. Um, oh, hold on. And so there's a lot of patients have a concern about a bone marrow draw. They hear horror stories from friends about, oh, I hear bone marrow biopsies are very painful, and there's often a lot of anxiety around that procedure. Um, in this slide here, I show some of the tools that we use to perform a bone marrow biopsy. This is in the middle here is a bone marrow trocar. So imagine it's a it's like a thick needle with a central insert that you can remove. The central insert has the sharp tip that is used to get into the bone. When you remove the central insert, you can then attach a syringe to it like we see over here and draw back on the plunger, and that's what is an aspiration is. So bone marrow looks like blood. A lot of people say, "Oh, is it clear or what does it look like?" It looks like blood, and when we do this procedure, it is a completely sterile procedure. The patient is scrubbed with surgical scrub and draped in surgical drapes, and I wear a surgical gown. Um, and it's much more much better tolerated than patients think. Um, and that's for a couple reasons. One is we offer a light sedation, IV sedation, where you're drowsy but you're not unconscious, and we can put short-acting pain medicines through the IV at the time of the procedure. Um, but in honesty, I have several patients who say, I don't want any drugs. I just want to do it without any IV medicines, and they tolerate it well. Um, one of the main reasons why it hurts is that the surface of the bone has sensation, but the bone itself does not have nerve fibers. So what we do is after we completely scrub your skin, I inject a local anesthetic through the skin down to the surface of the bone, and that numbs up the surface of the bone. Where people will feel the discomfort is from the pressure change when we're aspirating it with a syringe. And the way that we do it in Regenexx clinics is different than most other clinics. Um, and as a result, there's much less pressure change and much less discomfort. So these images here show the position that the patient lies in. You lie on your stomach. We come in on the back side of what's called the posterior iliac crest. And this zoomed in picture shows the edge, the outer layer of the bone is dense bone, but inside it's like a honeycomb structure. And this is a zoomed in diagram of what that bone trocar actually looks like. So we come in from the backside and I manually just kind of rotate the trocar back and forth with pressure and get into the bone marrow and aspirate a small amount of bone marrow from one level, from one depth. Then I advance the trocar about a quarter of an inch and take out 5 more milliliters and go a little deeper and draw out 5 more milliliters. And then I back out and I redirect not out of the skin, but out of the bone. And then we go into another site. And we do that at several sites along the iliac crest. So I mentioned that what people will feel discomfort from the pressure change when you're drawing it out. And in other clinics, they'll go into one spot and they'll quickly draw out a large volume of bone marrow, and that's painful. At Regenexx clinics, we draw little amounts at 3 different depths from multiple locations, and therefore there's not a big pressure change. So as every time I do one of these procedures, I'll ask the patients as I'm drawing the bone marrow out, tell me what you feel. And almost uniform 95% of the time patients will say, I don't feel anything, or I just feel a little weird sensation. And so that the reason is there's not a huge pressure change. The reason that we do it this way is the Regenexx research labs have studied this to look at and see how do you get the highest number of live cells from the bone marrow. And it's when you draw small amounts from several different locations at 3 different depths. So based on science, we do it this way to get the highest number of your own live cells. And as a side effect, it's much, much better tolerated. So in that bone marrow, I mentioned there's many different layers, many different lines of cells, which include stem cells and other progenitor cells, but there's red cells, there's white cells, there's basic blood, and there's platelets in the bone marrow itself. So one question patients ask is, well, if if platelets are in the blood, why don't they go to the area of injury automatically? Why do we have to draw the blood and then get the platelets out and inject them back in again? Um, and if and the reason is tendons, ligaments, cartilage, connective tissue structures don't have a vigorous blood supply, so it's hard for platelets to get to those areas. Whereas your skin has a vigorous blood supply, so when you get cut, you bleed immediately. The blood and the platelets hit the connective tissue, and the platelets start releasing their growth factors. But tendons and ligaments and cartilage don't have that great of a blood supply, so we extract large volumes of platelets, concentrate them into a very small volume of plasma, and inject them with precision into the areas that have been injured or are wearing down. So some of the areas that we can help you with are knee arthritis, patients who are of significant knee arthritis and are looking at needing knee replacement. We can treat that with good success. We treat shoulder rotator cuff tears, shoulder arthritis, the anterior cruciate ligament tears in the knee. Um, so we're able to help even patients with severe knee arthritis avoid knee replacement. And we know that because we've been tracking our data ever since starting this. And our data shows that even patients with severe knee arthritis are considered good candidates for procedure. Now, that isn't the case in all joints in the body. Hip arthritis does not respond as well. So patients who have severe hip arthritis, we'll say you are a poor candidate for procedure, meaning you may have a 1 in 3 chance of getting maybe 9 months of relief. So I'll tell patients, you know what, if you have severe hip arthritis, I'll say you're considered a poor candidate. Our recommendation is that you get hip replacement surgery. Some patients will say, I can't have surgery. I refuse to, or they have medical conditions that will preclude that. And some patients, even though they know they're a poor candidate, will say, I still want to do the procedure. Um, in patients with mild arthritis, we know we can help prevent it from getting worse. These are really disease modifying procedures. So yeah, that actually that number is actually of 2,800 knee procedures. That's actually from last month. I need to update my slides. Sorry about that. That number is probably over 2,100 right now because that data is actually 1 month old. But so we're tracking, let's say 21,000 patients with knee issues who have had procedures. Patients rate their improvement at 38% by 1 month and 51% by 3 months and 61% by 5 years. And their functional rating, if the patients on average would rate their functional level at 56% initially, and that increases to 66% by 1 month and 73% by a year and 76% by 5 years, with a 43% pain decrease by 1 month. And I tell patients, our goal is usually by 4 to 6 weeks for you to be able to say, yep, I can feel some improvement. And by 3 to 4 months to say I have significant improvement. And usually somewhere between 6 to 18 months out is where patients will kind of plateau at their peak improvement. So we also have advanced treatments for more advanced arthritis, and that there are very few clinics that can offer what's called intraosseous or IO bone augmentation. And that's a procedure where we actually treat the bone just deep to the surface of the cartilage in patients with more advanced arthritis where the bone is actually starting to break down. And I use fluoroscopy to guide that type of procedure into the bone as well as onto the surface of the bone. And that is backed by many years of research dating back to 13 years or more in France, and with similar studies done in the United States. So these pictures show what's involved with intraosseous bone augmentation. It's basically using a similar device, but smaller, a similar device that we use to extract bone marrow out of the back of the pelvis, and we put the concentrated bone marrow and platelets into the bone around the joint that's damaged. So we're able to treat knee ACL tears, ligament tears, meniscus tears with the knee. Now, not all ACL tears are amenable to our procedure. If it's fully torn and retracted, meaning the ends are separated from each other, our data shows it won't heal. But you can have a full thickness tear or a partial full thickness tear that is not retracted, or a partial tear that patients respond well to. We have great data showing that this works well for them. And you would need a recent MRI for us to see, is there a retraction or not? So we also treat moderate to severe shoulder arthritis, rotator cuff tears, labrum tears. And similarly, I mean, at some point, I'll go over some webinars on just specific areas like foot and ankle or hand and wrist and elbow. But the kind of the big areas are knee, shoulder, and hip. But there is a lot of hype around stem cells. Like if you were to log on to Google or whatever your web search tool that you prefer to use and typed in stem cell, you'd see numerous books and ads and all sorts of information on stem cell. There's a lot of hype around it. And there are really three kind of phases of adopting new ideas or new procedures. And the early phase adoption would be where people think, hey, this is amazing, this is magic. It helps everyone. Let's use it on everyone. And a little more advanced or more mature thought process would say, this is great and it helps almost everyone. And a more advanced or mature thought process would be, let's figure out who is a good candidate for this procedure. And that's what we do with everyone. With every patient, I go through our data on the patient outcomes registry, and then look at the patient specifically and look at things that may improve their candidacy or decrease their candidacy and come up with the final candidacy rating. So the biggest problem or biggest abuse I see is when patients are being told that they're having amniotic or placental stem cell injections. And I say that in parentheses because if you take someone else's tissue, be it a placenta tissue or amniotic fluid tissue, if you're going to inject that into another person, you have to sterilize it. And in the process of sterilizing it, all the live cells are killed. There are no live cells in these products. And this has been evaluated in several large institutions, and they've found that it's dead tissue with no viable cells. Now, the manufacturers of these products will say, well, there are growth factors. There's growth factors in these amniotic tissue products. And that also has been evaluated and been shown that there are more growth factors in someone's just plain blood. If you draw your blood and were to inject it into a joint, compared to what's found in the amniotic tissue products. And this is regulated by the FDA as dead tissue products. So because it's something that is marketed and sold and it is considered a drug under the FDA, and it's, like I said, it's regulated as a dead tissue product. Regenerative treatments that we do are not under the purview of the FDA. They're not drugs. We're not using your cells in someone else's body. We're not processing your cells and growing them for weeks and then injecting them. They're your blood or your bone marrow is extracted and processed and re-injected that very same day. And so it's considered a procedure. And so the FDA does not regulate procedures. They do regulate drugs and they regulate devices like artificial joints that might go into a body, but the, our procedures are not FDA regulated. There are numerous, I mean, there are more uh, research publications showing how well platelet-rich plasma and bone marrow extract concentrate works for orthopedic conditions. There are far more studies showing that than there are studies that actually show that surgery works. So it's well, all our procedures are well founded on scientific research and are backed by our long-standing monitoring of how well they work and how long they work. So that brings me to the end. We have time for questions. If anyone has questions, you can put them into the chat, or you can also send me an email if you want. But if you have any questions now, I can address them so everyone else can benefit from your questions. If you don't have questions and are interested in being evaluated for to see if you are a candidate for a procedure, the information on the screen shows the numbers that you can use to reach us, and also most importantly is the website. If you go to our website, there's a section there where you can click on to say what am I a candidate, and it'll ask you to fill in some information, and you then one of our patient education staff members would contact you and go over whether you're a candidate. So there's a question that is, what is the success rate in 90-year-old males? Now that's kind of a tough question because our success rate of all of our procedures varies from joint to joint. Now, if we're going to ask in general, does this work for elderly people or not? Then the answer is yes. For instance, our knee data shows that even patients with severe arthritis are considered good candidates, even as they get up into the older ages. I have patients in their upper 80s. I don't have many in the 90s, but I do have some in their 90s um, who have had the procedures and done well. One thing we have learned, and the Regenexx research labs have looked into this, is how fast will your own stem cells from your bone marrow repopulate or come back up to their normal levels. And that we do know is age dependent. So for instance, we have patients who may want to do multiple procedures with bone marrow extract. And some of them I may have to use as much bone marrow that I can extract from both sides of their hips. So but they may have other joints that they want to treat. So the question would be brought up frequently is, well, how long do I have to wait for you to go back into my bone marrow? And what we found is patients who are like under age 30, it takes about 3 months for their stem cell counts to come back up. And the worst case scenario is women over age 80 takes 8 to 9 months for their stem cell counts to come back up. And it's pretty linear. So, people in their 50s and 60s, I tell them give it about 5 or 6 months. But we do, well, and the age question also brings up a good point in that there is lots of research showing that the older a patient is, the higher the concentration of platelets you need to use to in order platelets that you need to use in order to be effective. And part of that is that it takes more growth factors to stimulate your stem cells in the area. So I mentioned how other clinics that do platelet-rich plasma, they're kind of limited to how high of a concentration they can generate from their bedside kits that they use. Um, that the the research looking at platelet-rich plasma concentration would show that for a young person, let's say under age 30, increasing the concentration of your platelets helps and makes is more potent or more effective up to a certain degree. And that would be if you concentrate your platelets uh, up to like 6 to 7 times your normal blood concentration. The benefits kind of plateau at that level for a 30-year-old. But as we get beyond that, the data shows you need to concentrate the platelet-rich plasma to higher degrees. So a 40-year-old, we'd be looking at somewhere in the 14 to 16 times your blood concentration. 50 to 60-year-olds, up to 20 or higher, 20 times your blood concentration is needed. And that really comes into play where because other clinics that aren't Regenexx clinics have to buy processing kits from a device manufacturer, and those kits vary dramatically as to how concentrated the platelet-rich plasma is that they can make. Some of the cheaper, not older kits may concentrate the platelets to only twice the blood concentration, or even 1.5 times the blood concentration. And some of the better kits will get up to around 6 or 7 times, but they don't come anywhere near to the 20 times or higher that we can concentrate in Regenexx clinics. So um, in that case, age definitely has an impact, and that's why one of the benefits of coming to a Regenexx clinic is we can concentrate your platelets specifically to your age. Um, Another patient, a person had a question that they have a family member who's in his 90s and has had a treatment at QC Kinetics. Can he start with our treatment? Yes, we uh, just as a side note at Regenexx, all procedures are done by a physician, not just overviewed by a precision by a physician like at other places. And yes, you can, if a patient has had treatments at other places, they can definitely have treatments here. I've had patients who've had treatments at the Mayo Clinic and call treatments at other universities and with limited success and have come to me for treatments. Um, so, and that brings up a point, and that is that once you have generally when I do procedures, I'll tell patients our goal is to have you to just do one procedure, but every now and then there are patients who do need to have a repeat procedure, and so we follow up with you. We generally will follow up in 6 weeks and then 3 to 4 months and then sometimes 5 to 6 months down the road. And if a patient is not getting a huge response, and that's a minority. It's a small minority, but every now and then patients will maybe plateau at a level that's not acceptable, and you can repeat a procedure. Other clinics that do PRP, they'll often say, we anticipate you needing to do one procedure a month for maybe 3 or 4 months. But because we can adequately concentrate your platelets to the level that you need individually, I generally tell patients this is going to be a one-time procedure for you. Um, let's see. I If someone recently had a procedure and how much can you walk? So we patients we generally want patients to start moving pretty quickly. We don't want you to start exercising right away, particularly after a platelet-rich plasma injection. I mentioned that the platelets will release their growth factors over 10 to 14 days. So we want you to keep the joint moving. Um, but we don't want you to start like overdoing it and doing repetitive motion over and over again, where you could flush those platelets out of the area before they've had a time to release their growth factors. And so, and that's another reason why we have patients work, we set them up with formal physical therapy, and we have post-procedure protocols that will help the therapist know how quickly can you start advancing your activities. And we remind patients that these are procedures that are promoting healing in your body. So you have to give it time to heal. Just like if you plant seeds in the field, then the corn doesn't grow overnight. It takes months to grow. Your body's own cells take months to grow. But that doesn't mean you can't do anything for months. In the early phases, we want gentle activity. We ask you to use a heating pad, not ice, because we want you to get more blood flow into the joint, not less blood flow. And then as you get out into, 4 to 6 weeks down the road, at that point, your body starts responding positively to gradually progressive stress on the tissues. And so we work closely with a physical therapist and to help them guide you along how quickly can you start advancing your activities. So a question was meniscus tears. Well, we treat meniscus tears all the time. Now, one thing to keep in mind is you may be told, you may get an x-ray and it shows you don't have much space between the bones in your knee, and they say, oh, you have a meniscus tear. Well, patients can have meniscus tears without symptoms. Meniscus tears generally occur over time. It's like I tell patients, you get wrinkles over time on your face, you get meniscus tears in your joint, in your knee over time. Um, Now, a young person, if they have a traumatic injury, they twist and they get a discrete tear of the meniscus. That's different than, let's say, a 70-year-old patient. Um, as we get older, meniscus tears are considered part of the spectrum of things that happen with osteoarthritis. So people like to focus on the idea of that, oh, I have a tear in my meniscus. And if you get an x-ray and it shows that you've got moderate arthritis, you've got an 85% chance of having degenerative meniscus tears. So in general, we would not just, unless you were a young patient that had a discrete meniscus injury and didn't have any other problems in the joint, we generally don't just treat the meniscus, we treat the whole joint. We treat the arthritis, we treat the meniscus, which is a fibrocartilage shock absorbing pad between the bones. We treat the laxity in the ligaments around the knee to make the knee more stable. And we treat the tendons around it. So, but we have good results with meniscus tears, and it's treating the meniscus is generally part of the multifaceted treatment of the knee arthritis itself. And yeah, there's a question, are there post-PRP injection protocols that we follow, such as activities? And yes, we have definite protocols that the therapists follow and that we discuss with our patients. One of the big things is we tell patients, do not use non-steroidal anti-inflammatory drugs such as Motrin, Aleve, ibuprofen, aspirin. We don't want you to use those for 2 weeks before a procedure and 6 weeks after, because they work by inhibiting platelet activity. And so if we're using platelet-rich plasma, we don't want to inhibit the platelets. But you can use Tylenol. Generally, patients will have some slightly increased pain for a few days after a procedure as the platelets are starting to release their growth factors, and then things calm down and slowly improve. So in the first few days, we'll tell patients use Tylenol. If we're doing a more advanced procedure, I'll give a prescription for a short-term course of a narcotic opioid analgesic if needed, but generally it's the biggest thing is do not use anti-inflammatory medications. All right. Looks like we have a couple other questions. Actually, one more. How do you treat hip labrum tears with arthritis? So the first thing is I'd want to determine what is the degree of arthritis. Now, x-rays can often underestimate the degree of arthritis. So if someone looks like they have arthritis on an x-ray, we'll generally get an MRI because we definitely want to see how much cartilage is left in the joint. Because if a patient has severe arthritis, they're considered a poor candidate even for our most advanced bone marrow extract procedures. But to treat labrum tears, generally we'll use high concentrated platelet-rich plasma injected into the labrum, which you can see on ultrasound, or you can see it with fluoroscopy guided injections. For more advanced labrum tears, we'll mix in uh, bone marrow extract and uh, and and platelet-rich plasma and inject that mixture into the labrum. Um, and labrum tears that's another area that is often patients focus on. Oh, I have a labrum tear, and yes, patients can have labrum tears and not even know it. Um, so you can have labrum tears that are asymptomatic and not causing problems. Um, you can have labrum tears that hurt and cause mechanical symptoms like clicking or popping. But when we see or if we suspect that a patient has a labrum tear, we'd get an MRI to show that, and that MRI would tell us to what degree they have the arthritis has progressed as well. But that's another thing, another example of when we're treating a joint. Let's say I have an arthritic joint. If there's degeneration or fraying of the labrum, I'll inject into the joint and also into the labrum itself. All right. Well, thank you for your questions. This uh, webinar will be available for you to download in the future as well, or to share with your friends. And again, I'd like to just direct you to our contact information slide there, and um, by all means, give us a call and um, talk to our patient education and scheduling staff, and we can do a thorough evaluation and let you know if you are a candidate for one of our procedures. Have a great night and take care. We will have another webinar probably in the next month, and I have not yet decided if that's going to be a shoulder or a knee specific webinar, but um, look for information in the coming weeks for upcoming webinars. Have a great night.